Welcome, everyone, to the People's Health Briefing, a key component of our Trusted Voices campaign. I hope you all had a safe and fulfilling holiday season and that your 2025 is off to a great start. I'm Dr. Noha Abalada from Roots Community Health, reporting for the week of January 6, 2025. As health professionals rooted in Oakland, serving some of the most marginalized communities in California, we're here to cut through the noise and bring you the latest information on health issues relevant to us all. As a quick reminder, if you haven't yet completed our survey about the People's Health Briefing, we would really appreciate your feedback. And you can be entered into a drawing for one of these 3 amazing gift baskets of soap and candles from Clean 360, a workforce enterprise of Roots Community Health. And the link to our survey is in the post. There is quite a lot to update on all things communicable diseases in the US, so let's jump right in. So we know we're kind of in the midst of what is called respiratory virus season, which is basically what we used to call flu season. And flu season generally starts around October and peaks somewhere around December to February. And we know that we have seen spikes of COVID in the winter and in the summer, and that there's quite a bit of COVID activity all year round, actually, which is much different than flu and RSV, where we have periods of little to no activity for much of the year. So even though COVID is year round and certainly creates a heavy burden year round, it is helpful during this time of year, this respiratory virus season, to take a look at the main respiratory viruses giving us trouble, which are influenza, SARS-CoV-2, and RSV. So first, let's take a look at emergency department visits for each of those illnesses. And this is looking at the percentage of emergency department visits that are due to each of these 3 respiratory illnesses. And this is looking at the past year. So to the far right is the most recent. It's actually showing all the way up to December 28th, 2024, so only about a week old. And if we look at the orange line, that represents the COVID-19. And we can see once again, it never goes down to the 0 line, and it goes up at other times besides just in the winter time. We can see that big summer bump that we had this past July, August, September. And the blue line, which is flu, really follows that winter pattern for the most part. And as I said, we can see the peak somewhere between December and February typically. And we can see just around this past mid-November or so, the blue line, which is the flu, crossed over the orange line, which is the COVID, and has just been heading straight up since. And this is because the percentage of emergency department visits that are from flu has been increasing significantly, at least through December 28th, which is what we can see so far. But also because we were enjoying a little bit of a reprieve from COVID in early November, but we know that things have been kind of heading up as well since then. So COVID and RSV are increasing, just not as steeply as influenza, but they are increasing nonetheless. So the bottom line is that all 3 viruses are increasing in terms of the percentage of emergency department visits they represent, meaning people are getting sick enough with these viruses to present to the emergency department. Also, this means a greater overall burden to our health systems as all of these viruses head up. And also that unfortunately means more hospitalizations and more deaths. But taking a look at deaths from viral respiratory illnesses, so COVID, flu, and RSV are shown here. And as we can see, the COVID deaths in the orange, they happen all year round. So they go up, they might come down, they go back up, and they come down, but they are occurring all year round. And flu, really, we have a flu and RSV season. So the only really times when you see flu and RSV deaths are during those seasons, which are really just getting underway here for this year. So we've just started to see a little bit of flu deaths. Those are in the blue. Really haven't seen any with RSV yet, but COVID continues to do its thing. So I think this graph makes it very clear the extent to which COVID deaths really eclipse anything we're seeing with influenza and RSV combined, actually. in the entire year, even during so-called respiratory virus season. And this is why we continue to pay attention to SARS-CoV-2 surveillance, because it really doesn't follow much of a pattern of predictability, and the burden continues to be considerably high. And it does also seem to be the case that our behavior drives much of the COVID surge activity around times of increased traveling, increased mixing. So this is one of the reasons why we continue to monitor what's going on in the wastewater and other early indicators of SARS-CoV-2, because that can let us know that more illness, more hospitalization, and more death are impending. And hopefully at some point, this can also help us to change our behavior. Taking a look at COVID in the wastewater nationally, we can see that it is high. So it is climbing up nationally. And this is happening to the greatest extent in the Midwest. And so you can see there that the Midwest is already in the very high region. And the South, just a little bit below the national average. Northeast is heading pretty sharply up there. And the West is a little bit flat at this point, but we will just continue to keep an eye on that. And if we want to kind of get a closer sense of what's going on in these last 45 days, we can see that, again, all areas really are heading up, just to differing degrees. So by the looks of both our early COVID indicators, wastewater and emergency department visits, it appears that we kind of reached our COVID low point somewhere in mid-November, and that both of these early indicators have essentially been heading up from there. So we have to keep that in mind as we look at deaths, because now we can kind of anticipate what we might see there. So basically, if the patterns from the past hold, we would expect to see deaths falling behind by about 4 to 6 weeks after the rise in emergency department visits. So by that estimation, we might see a low point in COVID deaths in late December, early January. So taking a look at COVID deaths, and we currently only have complete data going through the week of ending December 7th. So we only have the early December. And indeed, it is coming down a bit, 432 deaths that week. And remember, even in our lowest point of the entire pandemic so far, which happened sometime last summer, we never got below 300 deaths per week. So once again, a very high burden from this contagious virus that is spread easily through the respiratory route, and of course affects all organ systems, in addition to causing hospitalization, death. It causes a whole host of post-viral issues as well. So still a lot of things that we need as it relates to SARS-CoV-2. Still some things that we're hoping for some answers on long COVID, hoping for some treatments on long COVID. Another hope is that we'll get a better COVID vaccine in the coming months to years that will give us more durable protection. Right now, the vaccine doesn't offer too much protection against COVID infection, except maybe the first couple of months after you get the vaccine. It still continues to protect against severe illness, which is great, but it's also a little more short-lived than we would like there as well, especially in those at greatest risk. So for those who are truly at risk of a poor outcome from an acute infection with COVID, so those who are older, those with underlying conditions, those with immune compromise, the vaccine would likely be needed at least every 6 months to offer that protection against severe disease. And of course, those are the same individuals where we would want to ensure timely access to treatment as well. But with all of the travel, the gathering, the mixing, the lack of masking indoors, we pretty much continue the unmitigated spread of SARS-CoV-2. We continue losing hundreds of people in the United States alone every single week, even during what we would call a low period such as now. But still, over 400 deaths per week is still too many, especially when we know that in the coming weeks, we can expect that to head back up. So even though it has remained quite clear that COVID is creating a burden that is orders of magnitude greater than flu and RSV combined, up until now, it has been kind of difficult to make apples to apples comparisons. And there's a few reasons for that. One of those is that the burden of flu is always represented by the season, whereas COVID and RSV historically have not been. And although we have a lot of practice with flu, like creating models and things like that, those have been developed over the years and decades to share estimates of the burden of flu. We really didn't have that for COVID or even for RSV. So this year there's been what I think is a really important development, and that is that the CDC has released what it calls in-season estimates for COVID and RSV to go along with what they've already been doing for flu. So this allows us to take a look at these things kind of side by side, which I hope will really help folks understand the relative burden of each of these viruses so that we can stop hearing anecdotal conversations that don't get us anywhere. So instead of opinions about what's mild and what's a big deal and what's not, and what's better, what's worse, we can actually look at the burden estimates side by side. So there's a lot that goes into creating these estimates. There's a lot of caveats to it. None of it is perfect. If you're interested in all of that detail, the link to all of this information is in the post. But I think this information will really be helpful, not only to the average person who wants to be knowledgeable about all of this, but also to public health officials and healthcare systems leaders to help them with planning and with health education and preparing for the impacts on our healthcare delivery system as well. So I've taken the 3 infographics the CDC created and put them onto one slide. So if you want all the footnotes and details, you can check them out by the link in the post. But basically, these are the estimates of the burden of RSV, flu, and COVID from October 1st through December 7th. So just a little over 2 months. And I think we have to take the illnesses and outpatient visits, especially with a little bit of a grain of salt. And that's because a lot of times, as we know, people get sick with these things and never present for care. They don't get tested, but that's where some of the modeling and estimating comes in. But I really do want to hone in on the hospitalizations and deaths. And that's for 2 reasons. First, these are much more reliable data, still not perfect, especially hospitalizations. This is just becoming required reporting, just became required reporting in November. I do expect this metric to actually get better, get more accurate and more complete as time goes on. Death, we know, is a very good metric. It's also not perfect, but it's probably the best metric we have. So taking a look at hospitalizations, it's up to 45,000 with RSV in those 2+ months, up to 33,000 with flu, and up to 120,000 with COVID. So essentially 3 to 4 times the number of hospitalizations from COVID compared with flu or RSV. And if we take a look at deaths over on the far right, up to 2,300 from RSV, to 3,200 from flu, and up to 13,000 from COVID. So even if we add up the flu and RSV deaths, COVID is more than double flu and RSV combined. And remember, this is during the season where we actually have flu and RSV, because other times of year we really don't. Now, we just saw that flu is on the rise, so this picture will certainly look different as it gets updated, and I do hope that it does get updated. I also hope that this signals that the CDC plans to do a better job of comparing the burdens of these illnesses. And in my mind, that would include looking year-round, not just during the respiratory virus season, but we will wait and see what they do next. And now just to take a more updated view of the flu, as we've seen, it's heading up. And remember, the slide I just showed was only through December 7th, whereas this is showing us through December 28th. Seasonal influenza activity continues to increase. It is elevated across most of the United States. So far this season, there have been approximately 5.3 million flu illnesses, about 63,000 hospitalizations, and already 2,700 deaths. And this includes 11 pediatric deaths. The vast majority of flu cases are influenza A, so about 97% are influenza A. Only about 3% have been influenza B so far. And within that influenza A, there are a few different subtypes that we're seeing. About 55% are the H3N2 subtype, and about 44% is the H5N1 subtype. And This is mainly only important as we want to check how the vaccine is doing and how the medications are doing against these different subtypes. We really don't otherwise worry too much about that. When we take a look at how well the vaccine is doing this year, it seems like it's doing very, very well against the H1N1s, a little less well against the H3N2s, but still vaccination is going to offer us the best protection against the flu. It's not too late to get the flu vaccine. As we've seen, we're kind of in the beginning of the rise of flu. We haven't even reached the peak, so there's plenty more time for flu to be causing problems. So now is a great time to get the flu vaccine if you haven't gotten it yet. Also, those who are at risk of a bad outcome from flu, we want to get early antiviral treatment. That's going to be your best bet from keeping it from progressing to more severe disease. So far, there appears to be very good sensitivity of all of the subtypes of flu that we are seeing against the antivirals that we use, and that includes things like Tamiflu. And of course, the other subtype of flu is H5N1. Now, the key thing here with H5N1 is that unlike all the other influenza strains that I just mentioned, this is the only one where we have not seen any human-to-human transmission. And hopefully we will not see any human-to-human transmission, but of course we know hope is not a strategy. So far, there have been 66 confirmed human cases of H5N1 bird flu in the United States in this current outbreak. Over half of those are in the state of California, so 37 so far in California, Washington with 11 cases, Colorado with 10 cases. So really more predominant in kind of on the West Coast, but some very sad news to report is that the first and actually only reported case so far of H5N1 in the state of Louisiana has ended in death. So this is the first human death from H5N1 in the United States in this outbreak, which has been going on for close to a year now. This particular person was exposed to birds apparently at their home. And just overall, there's been very little information so far about this individual or their course of the disease. Although I will note this headline and many of the news articles about this tragic situation have pointed out that the patient was over 65 and had underlying medical conditions. And yes, we always want to look at various details about a patient, but to have this show up in the headlines this way is definitely bringing me some concern. So first off, it's really kind of out of context. We don't know anything about the age or underlying conditions of the other 65 or so H5N1 cases that we've encountered so far in the United States in this outbreak. So telling us that this person who got it in Louisiana and who succumbed to the illness is in that age group and has underlying conditions which are not named is not necessarily useful. In fact, I'm concerned that it is being stated in an effort to downplay what is otherwise a very serious situation. It is our first human death in this outbreak from H5N1, and this is something we should not be just excusing away. And it's making me particularly concerned that we have not actually learned our lesson from the SARS-CoV-2 pandemic that we're still dealing with, where way too soon people were coming out emphatically saying this is only going to harm people who are older or people who have underlying conditions. We don't need to worry about anyone else. And we all know that that turned out to not be the case at all. We've lost over 20 million people worldwide from SARS-CoV-2. And all that downplaying was happening at the beginning when we didn't know much. And it simply did not help the situation at all. We lost people in literally every single age group. And we lost quite a number of people in under the 65 age group. So 40s and 50s and early 60s, people who were working and more likely to catch it before we had vaccines and so forth. And so this was literally a fatal mistake that we mischaracterized the virus, a virus that was new to us. We should have known better. We should have reserved all of those opinions and waited until we actually had more data. And it just feels a little like we're heading in the same direction with this situation, trying not to upset people or alarm people, but essentially characterizing something we really don't have any business characterizing just yet. And that could be very misleading. And so having headlines that are just meant to reassure people or imply that people under 65 or people without underlying conditions don't have anything to worry about, and really sort of ignoring the fact that a huge percentage of the US population actually has underlying conditions, whether they like to admit that or not. And that people 65 and up still can expect many years of life ahead of them. So this idea of thinking over 65 underlying conditions, that it's just a meh, it just really bothers me and makes me feel like we have not learned our lesson at all. So we just don't have enough information. Things are really evolving with this virus. Things are progressing and marching forward. And so I think that we should be a little bit more humble this time around. Just a thought. So the Louisiana Department of Public Health is not sharing any further details at this time, but maybe we'll see something later in terms of a case report or something that will give more details and shed more light on what happened with this individual. But like I say, no matter how you look at it, this represents a progression of our situation with H5N1. We have our first death in the United States. This is not something we should take lightly. I'll also point out that the second most severe case of H5N1 so far in this outbreak was in a young person in Canada who did not have underlying conditions. They were only 13 years old. We finally have gotten some updated information through this correspondence published in JAMA on December 31st about this young person. And so this is a 13-year-old girl in Canada who became critically ill with H5N1. It appears we still have no clue where she contracted it. And she did survive, but only after a prolonged ICU stay with a lot of major interventions. So not only did she have antiviral treatment, oxygen, and so forth, she was actually intubated. So she was on that breathing machine with the tube down the trachea to be able to breathe. She also was on ECMO. So this is basically life support. So pretty much when the lungs and the heart aren't working properly, and they pretty much need a rest, and the machine is doing that for them. So these are pretty serious measures. Her symptoms started out very mild. She basically had the pink eye or the conjunctivitis in both eyes and a fever. So she was originally sent home thinking it was just a viral thing, which it was, but it was not a mild viral thing. It ended up progressing very quickly. She came back to the hospital and was admitted. And then admitted to the ICU. She ended up in respiratory failure with pneumonia, with kidney injury, among other things. So incredibly serious illness this young person endured. Certainly grateful to the team who took care of her. Very glad that she survived, but this was an ordeal that will take time to come back from. So this is difficult for the patient, for the family, and it takes a long time to get back to yourself after going through something so severe. And we don't know whether there will be long-lasting effects or post-viral effects or anything like that, because we just don't know yet. And I think the other thing that this highlights, other than the fact that this was a child without underlying conditions who got this critically ill, we don't even know where she got it yet. This is another huge, just kind of question mark. That's kind of a big question mark. And I think it also is clear that we do not have the capacity to handle, if this became a very widespread thing, to have people of any age, I suppose, having to have these kind of ICU stays, ECMO, and so forth. So this is kind of a big deal. These are things for us to keep in mind when we're thinking about what a response to this would look like. So the good news is so far that these two cases that are very severe seem to be the only two cases that are very severe so far. The other good news is that, well, it's not good news for that, for those two individuals, obviously, but for the overall picture. The other thing is that there's been no human to human transmission. So those are reassuring parts. So not even in the hospital or among family members and things like that. We don't have any known human-to-human transmission thus far. So those are kind of the only reassuring parts. The not reassuring part is that this thing just keeps marching along, and it is spreading like wildfire through cattle and through poultry. And we know that it has pandemic potential, and that potential just keeps increasing with the more different types of animals that it affects. We know that it has killed some cats, and the more that it crosses over into humans, every transmission is an opportunity for more mutations, and it only takes so many mutations before this becomes something that could efficiently spread between humans. And we can hope that that doesn't happen, but we need to do more than that. So for now, the guidance on an individual level remains the same. Please don't touch dead animals. Please don't touch wild birds, all of that. If you get sick, if you're suspicious that this is what it could be, if you have exposures, if you get a flu-like illness, and especially with the eye infection, the red eyes, that does seem to be something that has been consistent, then it would be worthwhile to be seen and get tested. A lot of times they can tell you pretty quickly if it is the flu, or they may even be able to tell you that you have flu A. It won't be until later probably that they would do the subtyping and see if it's H5N1 or something else. But in the meantime, the test is the same and the treatment is also the same. So you can get tested and kind of advocate accordingly. Other than that, I think right now it's really more of a concern about how this is being handled at the population level. And there are many things to be concerned about in that regard, including the leadership that is going to oversee this response and how this may unfold. So in the meantime, the best I can say is that we have to maintain our best practices to prevent the spread of respiratory illnesses. This includes vaccination, wearing a filtration mask like an N95 or KN95, particularly when you're in indoor crowded environments, gathering inside and so on. Gather outside whenever possible. And when you're indoors, improve that ventilation and filtration. And then certainly timely testing, especially if you're someone who needs to be treated, if you're positive, but even just in general, so that you can properly isolate and prevent spreading what you've got to others. And just a quick reminder on those respiratory illness vaccine recommendations. So for most people, COVID is going to be annual, but really probably every 6 months for a significant swath of the population. And that certainly probably would have been helpful to mitigate the summer surge that we had last year. But right now, the recommendation, strictly speaking, is 65 and up or moderate immune compromise for the every 6-month vaccine. Otherwise, it's annual. Flu vaccine, if you haven't gotten it yet, now is a great time to get it. It's a pretty good match for most of the flu we're seeing, not all. So you could still get the flu even after the vaccine, but it will reduce your risk of a bad outcome. And RSV for anyone 75 and up, or those 60 and up with underlying conditions or living in a nursing home. And lastly, we have a new recommendation on the pneumococcal vaccine. The age recommendation lowered from 65 and up to 50 and up. So pneumococcal vaccine is for those under 5 and those 50 and up. And remember to eat a balanced diet, incorporate fresh foods, avoid sugar, avoid those sugary drinks, avoid that processed food, get some regular physical activity. Unless you don't feel well, in that case, please get your rest and manage those stress levels and get a good night's sleep. This concludes the People's Health Briefing. Please remember to take a moment to complete our survey linked in the post. And thank you so much for joining us. We'll see you again next Tuesday at 10 a.m.